Uh, Very good morning, everyone. Welcome again to Indian Society of Gastroenterology Masterclass Series 2. Happy Independence Day to everyone. This has been a pleasure to welcome all of you on this very Sunday morning on a very important day, that's Independence Day. Last year, during the COVID pandemic and lockdown, we have initiated ISG Masterclass Series 1, and we had 32 lectures that point in time. Each one was wonderful. So we had a lot of feedback coming from a lot of DM, DNB trainees, and also from many of the faculty of faculty of gastroenterology, that why don't we run a clinical case discussion? So last year we wanted to do it, but we could not do because of a number of other things happening in the country, like many other webinars and other things going on. So it was always a dream to initiate a masterclass on clinical case discussion with residents and fellow trainees. So the dream came true today. Now we're starting our first session on clinical case discussion. And the focus here and objective here is to learn or learn the clinical symptoms and interpret that what disease the symptoms are caused by. And this is very important, and which I learned from Dr. Gaurav Chaudhary. He always said that DM and DNB is not about making a diagnosis. It's about making interpretation of symptoms and understand from that and make a diagnosis. So the whole objective of this Masterclass Series 2 is to accomplish that objective and learn from each other that how do we interpret the clinical symptoms and make an appropriate clinical diagnosis. It's not important to make a right diagnosis, but it's important to make a logical diagnosis. Making a right diagnosis certainly is very, very important, but we have to follow a logical pathway. Otherwise, we believe that this is all, we saw this, I've been tripped about the diagnosis, and therefore your evaluation may not be very appropriate. So with these few words, let me introduce to, and in this series, we'll have a 12 clinical case discussion. And if the program goes well and it becomes a learning experience for all of us, then probably do some more. But at this time, we have a plan to do 12 clinical case discussion, all at same time, all using same link. Same time means 11:30 to 1 o'clock on every Sunday from today onwards, till 12 Sundays. With this, let me invite Dr. Kocher, Dr. Rakesh Kocher, who has been my teacher and who always impressed me with his dedication to work and diligence in his dealing with patients. The Kocher presently is the president of Indian Society of Gastroenterology, and he'll address to you. Kocher, sir.
Well, good morning, everybody, on this auspicious day. As Dr. Govind has briefly introduced, this is a masterclass in clinical gastroenterology, and a series of 12 such sessions will be held. And the idea is to have interaction among a select group of faculty, different for each masterclass, with DM, DNB residents from different institutions across the country. As has been brought out very well, that it is not important to reach the correct diagnosis, but it is important to analyze history and physical findings in a logical manner. Any bedside discussion is, you cannot teach anyone in 1 hour or 2 hours. So the idea of any bedside discussion or clinical discussion is to generate curiosity and insight into the nuances of clinical gastroenterology. So I think the learning point of this kind of activity will be that the residents, DM or DNB students, go home and brush up their gastroenterology, the pathophysiology of disease, how to interpret symptoms and signs, and integrate them into a logical
Is Dr. Kocher audible to all of you?
No.
Okay. Right. So I think there's some audio issue. So taking from there, I mean, let me introduce to you the faculty for today. We have Dr. B.S. Ramakrishna. I think all of us know him. He is one of the best known luminal gastroenterologists in our country. His work has been in luminal gastroenterology have been tremendous, and we believe that he is teacher to all of us. Dr. Ramakrishna presently is director of sectional gastroenterology at SRM Institute of Gastroenterology at SRM Institute of Medical Sciences in Chennai. Welcome, Dr. Ramakrishna.
Thank you.
And we have a second, again,
a lecture kind of a thing on chronic diarrhea, followed by a clinical case discussion. Presentation by the residents from AIIMS today. Next time it will be another institution and so on. So over to the AIIMS team.
Yes, and the coach, you have not been audible for in between for a couple of minutes. So let me also introduce Dr. Varghese Thomas, who is again, he was a professor of gastroenterology, head of gastroenterology at Calicut Medical College, a esteemed teacher. Presently is at the Malabar Hospital in Calicut. Dr. Thomas has conducted a session for residents in southern part of India, and he's one of the passion, I would say, is to teach. So, and you know, the Kocher is again one of the best teachers in our country. So, with I've also joined as a faculty. So, 4 of us in the faculty side to discuss the case, and we have 2 very bright residents from AIIMS, Dr. Mukesh Ranjan and Dr. Samagra Agrawal. Both of them are 3rd year residents, and they will appear exam in December. So what Mukesh and Ranjan, Mukesh and Dr. Samagra will do the case presentation, and we'll discuss the case. To all of you who are joining on this clinical case discussion, we request you to please put your question or comments on the chat box, and we'll visit the chat box as in when we get to the case. We want this to be very interactive, engaging session. And we want this to be a very learning experience for each one of us, so that we go home with some point learned today. We are not going to rag Samagra and Mukesh. They are the clinical discussants, and we all 6 of us do together justice to this case and bring back the objective that how do we interpret or how do we reach to a diagnosis in patient who presents to us as a chronic diarrhea. With this, I will briefly summarize, present a case, not case, I mean, how to interpret the patient with chronic diarrhea. I would speak for 5-7 minutes and then hand over the case to Samagra and Mukesh. Dinesh, can I share my screen? Yes. Is my screen visible to all of you?
Yes.
Yes. So what are we going to do? That how do we approach a patient with chronic diarrhea, and what are the basic principles in addressing that? So first, the first question comes that, and most important to making diagnosis of chronic diarrhea is about looking at the stool, that how the stool is, and that gives the diagnosis. So while approaching, what is important? Is it frequency? Is it liquidity or fluidity of stool, or is it a volume of stool? All 3 are very important. And let me address why the 3 are important. And so what drives frequency? We all know frequency is driven by rectum. Once stool comes to the rectum mucosa is sensitive, and it drives the reflex, and therefore the signal goes to brain. Then you get a contraction of rectum and all other activity which happens at the pelvic floor to lead to passage of stool. And in those pelvic floors, the synergia, the stool passage may be obstructed. And these patients have a persistent stool in the rectum. Therefore, there's a repeated desire to pass stool. They have more frequency, but this is not diarrhea, because high frequency is not always means diarrhea. It's type of stool which makes it diarrhea. So those patients who have pelvic floor dysmenorrhea will have high frequency, but this is not called diarrhea. Now come to looking at, so high frequency is not the indicator for diarrhea always. Coming to what drives the fluid or liquidity to a stool. And we all know that liquidity of stool occurs because of volume secreted in the small intestine in the conditions of acute infective enterocolitis, can be because of malabsorption, and also it can be because of secretory disorders. The disorders of hormonal release, which can lead to a lot of more secretion of hormones and lead to a lot of water secretion in the small intestine. And it has a very special characteristic. I'll come back to that in a minute time. So the effluent of small intestine volume, it comes to the colon and it is absorbed. So what is the efflux is not the reflection of the disease. Efflux of stool is after colonic passes through the colon. Therefore, the content of small intestine has been modified by large intestine. Please remember this, that even there's a diffuse mucosal disease of small intestine, the stool may look to be normal to patient because the volume have been absorbed, which large volume came to small intestine, from small intestine to large intestine, but large intestine absorbed majority of volume. Therefore, the volume may not be large always. So therefore, keep in mind that all small bowel diseases do not have large volume at every time, and all because of a colonic effect. So normal definitions we know is more than 3 stools and volume is more than 200 ml. But most important is the Bristol stool chart. I'm aware, and even myself, I was not using this chart in my young days, but as I understood the importance of this chart, I started using it. And this is very important concept. This is just not the name of Bristol stool chart, it's an important concept. What is the concept? Normal stool is type 3, or type 4, right? Longer they stay in the colon or in the rectum, these stool become drier because of colonic absorption. Colon absorb water from the stool and they become dry. And as they become dry, the surface becomes very, very kind of, and they break as it becomes more dry. So as you go up, the stool is more drier. It is no volume to it, right? And as you go down to this, we have more water in the stool. So type 4, type 5, type 6, type 7 has more water. Means what? That stool is not able to get dehydrated in the colon. It means that there's more volume is coming from a small intestine to large intestine, and therefore this water is not enoughly absorbed, and therefore this is a type 5, type 6, 7. So this tells you the amount of water in the in the stool. Higher grade, less water. Lower grade, lower grade in the sense lower in the table, lower in the chart, they have more water. Please remember this while making a diagnosis. Sometimes patients say, I have 4 frequency stools, a stool type is type 1 or 2. So this is not chronic diarrhea. Frequency is not only thing which is important. Important is the type of stool. And this is the most important thing while interpreting a patient's chronic diarrhea. And coming to one other important point, which is the volume. High volume or low volume. We all have been taught from the very beginning, low volume means large bowel disease. Small intestine should have a high volume, but I told you, even a small intestine may not have high volume because of a colonic effect. The colon absorbs this water. The other important thing is the content and type of stool. And the content type of stool is, again, a very important concept. Those patients who have a secretory diarrhea, they will have more water. So if the colon ever releases more water in the stool, it is nothing but secretory diarrhea. Please remember this. Acute diarrhea, acute infective colitis, like cholera or infective colitis, they have more water in the stool. If this happens time and again, multiple times, repeated episodes, this is nothing but the secretory form of diarrhea. Large volume watery stool has just one meaning, that this is a secretory form of diarrhea, and we often miss in clinical practice. So if a stool volume is high volume, high frequency, watery content, high volume, high frequency, and volume is watery, is nothing but secretory diarrhea. Please remember that. And they require a special form of investigations. If you do upper GI endoscopy, colonoscopy, they will not lead to diagnosis. High volume, high frequency, watery content is nothing but secretory diarrhea. High volume, high frequency, low volume is more likely to be a large bowel type, and high volume or normal high volume in small intestine. So small intestine don't have any special characteristics, but large volume, it may suggest small intestine type. We know etiology of small intestine, large intestine is huge. We are not going to go in depth of it. You are all aware about, and we discussed this point in clinical case once we discuss the clinical case today and important cause of chronic diarrhea. Same large intestinal diarrhea have different causes, functional and organic. So we'll look at that. I make a point that tuberculosis is not important for the chronic diarrhea, which is often discussed in clinical bedside. And how do you approach? Again, all of you know about it. There are 6 or 7 points. If you look at in clinical bedside, a clinical query at while in outpatient or inpatient, we define acute and chronic, functional, organic, small bowel, large bowel, volume and content of stool. To me, this is a very important point. Do they have malabsorption, painful, painless, bleeding disorders, or inflammatory, non-inflammatory? And I might not like to discuss this with all of you because this is a very simple, common things which we have discussed at multiple occasions, how to differentiate functional and organic, which I'm sure Dr. Samag and Mukesh will discuss in the case discussion. But to remember, one important point, the enhanced gastrocolic reflex may point towards a functional disease and duration towards functional disease. Similarly, if you look at small intestine, large intestine, one important part to differentiate is the volume and content of stool. Content is malabsorptive stool, is a small intestine disease. If there's a blood in the stool or mucus or pus, it tells you that the rectum is involved. Tenesmus means rectum is involved, not the whole large intestine. Tenesmus means rectum. Volume of content, I already told you, large volume, high frequency is a secondary form of diarrhea. Look at features of malabsorption. Once you look at the symptoms of a carbohydrate, fat, and protein. Carbohydrate, you can have weakness, clotting, flatulence, borboremy, or distension. Fat loss could be because of low body fat. Low BMI is indicator of low body fat. And steatorrhea, which is not very common symptom, if that is there, that tells you that there's a fat malabsorption. And protein we define into 2, visceral protein and somatic protein. Visceral protein is a body protein, muscle mass, and somatic protein is a muscle mass. Visceral protein is albumin. Albumin means edema or ascites. And please remember, if somebody has edema and ascites, please always consider lymphatic blocks. Normally, chronic small intestinal disease will not much have edema and ascites. But whenever you see this chronic diarrhea and edema, always think of, is there a lymphatic block? It is a disease called lymphangiectasia. Look for vitamin deficiency, and these are very, very important clinical features. Again, you will like know the cause of small and large intestine are many inflammatory and non-inflammatory, and look at inflammatory features in terms of fever and joint pain. We have inflammatory disorders like tuberculosis, Crohn's disease, ulcerative colitis can have these features, but other mucosal disorders may not have these features. Pain abdomen, if diarrhea also associated with pain abdomen, then remember 2 things. One, that anybody who has a chronic diarrhea will have abdominal discomfort. And all of us has our own personal experiences. That acute diarrhea, large amount of water in the small intestine contracts, that leads to pain abdomen. But there's a crampy pain abdomen which relieves with passage of stool. So this is a different pain. So any pain which relieves the stool is because of content got released from a small intestine to the evacuated as a stool. But if the pain persists, and pain like intestinal colic which persists, then tells you there's a luminal disease. And this is again important point that we're talking this pain about luminal disease, which means there's a stricture in small intestine. There's a mucosal disease along with there's a stricture in the small intestine or large intestine can have this kind of. So all mucosal disorders will be painful, painless generally, but disease like Crohn's disease or IPSID or could be painful. Also remember that we always talk about chronic pancreatitis, but chronic pancreatitis is a totally different disorder. Only few patients, and are hardly to see patients with chronic pancreatitis who present to us with chronic diarrhea. They will come with pain abdomen like chronic pancreatitis, and diarrhea, you ask them, they will say, I have diarrhea or I have steatorrhea. but they will hardly come to you with steatorrhea. So chronic pancreatitis skipping diagnosis in a painful diarrhea is not appropriate. Also look at bleeding manifestations. Bleeding means there's ulcer in GI tract, somewhere ulcer in GI tract. Therefore, it's a more of inflammatory disease. Bleeding with chronic diarrhea is a more of inflammatory disease, but also please mind that if there's a hemorrhoids, which is very common in population, 10% of our population has hemorrhoids. If they can bleeding, they have chronic diarrhea because of diffuse mucosal disease, but they also have hemorrhoids. Let's not confuse, right? Therefore, to know more about bleeding is important, and localized bleeding separately. The bleeding causes this, diarrhea is this. Now, both together, what is the diagnosis? So put them, all of them together. So whatever information you got, put them together. And if put them together, you always have automatic diagnosis. For example, you talk about age, gender, duration of disease. You summarize the patient, small bowel type. Suppose we're giving a case, organic in nature, features of malabsorption, painless, having no blood, have no feature of inflammation. What the diagnosis? Diffuse small intestine disease, because malabsorption tells you the diffuse disease of small intestine. If part of small intestine affected, will not lead to malabsorption. If there's a malabsorption, it simply means there's a diffuse involvement of small intestine. Take a different case. Age, duration. We talk about 6 years duration of the symptom in a 45-year-old person, large bowel type of diarrhea. Looks functional in nature. Pain, they're often pain, no blood, no inflammation. What the diagnosis? This is a functional GI disease. Likewise, ulcerative colitis, likewise, secretiform diarrhea. Look at this patient. 3 years, organic disease, small bowel type, large volume, watery. There's urgency, no blood, no inflammation, nothing but secretiform diarrhea. So, taking a good clinical history, give a good examination, summarizing them into systematic order, and you will make an interpretation. You might be wrong in your final diagnosis, but that's immaterial. I think with this, I'll stop here and with this introduction and request now Dr. Samagra Agarwal and Mukesh Ranjan to start the clinical case, and we go by and then we discuss the case. Again, request all of you to put the questions in the chat box, and we try to address to these questions as we go along. Samagra and Mukesh.
Thank you, sir. First of all, I would like to express my gratitude to Professor Makharia, Professor Kochar, Professor Thomas Varghese, and Professor Balkrishnan for making us part of this. And without wasting much of time, I would like to proceed with the case presentation. Right. So I will start with the history of. I will start with the history first, then will be followed by the general examination and other part by Dr. Samagra. So we have a very interesting case. I think after listening to Professor Makharia, we will be able to correlate now well with this case. This gentleman, Mr. MKS, who is a 31-year young male without any non-prior comorbidities. He is resident of West Champaran, Bihar. He is an energy auditor in Department of Electricity, and he says he has to audit the energy consumption. For that, he is out of the town for most of the days in travel, so all over the India. He is married for last 3 years and has a baby. As I said, he is most of the time out of the town and consumes meal from out of home. That means from hotel he stays. Coming to the chief complaints, his symptom dates back to 2017 when he started having loose stools. And what he describes his symptoms as watery, and what typically he says, his stool is like water of dal with no solid content in it. That's a Mansoor Bristol stool chart of 7. He passes 15 to 20 such foul-smelling stool every day, and he has significant nocturnal frequency. That means he has to pass 5 to 6 stools after falling asleep, and that hampers his sleep as well. He says he has jets of large volume diarrhea coming out every single time he goes to stool. He says he has to run for this pass his stool. He has urgency, and at times he also has incontinence while he is asleep. Every time he passes the stool, the stooling is preceded by gurgling sound and colicky pain, predominantly in periumbilical region. Coming about the progression of symptoms, he says the diarrhea presents is almost every day. The symptoms frequency and severity has been increasing over the period of time, and right at the onset, over the first 5 months, he had significant loss of weight of 20 kgs. However, he states he has preserved appetite. Few of the episodes of diarrhea were severe, requiring him to be admitted. There is no associated blood, mucosal, or oil droplets in his feces. He has no associated fever, night sweat. There is no associated episode of frank bowel obstruction. That means distension, recurrent vomiting, inability to pass, feces or flutters. There is no clear-cut aggravating factor. There is no relation to meal or fasting. And he also denies any history of stomatitis, glossitis, vision impairment, bony pain, or arthralgia. Some relevant past histories. Few of the episodes of diarrhea improved actually with antibiotics alone that he took by himself from the nearby pharmacy. And as I said, he was admitted at a couple of occasions for severe episodes that too subsided with conservative treatment with antibiotics and IV fluids. He remains well for around 20 days after remission of symptoms. However, the symptoms recur and he cannot recall any aggravating factor as such. Now, I would like to highlight some treatment history. In 2019, he was treated with tinidazole and cotrimoxazole for 3 months, along with gluten-free diet from one of the attending physicians. And he says after taking this, he remained quite well, absolutely fine, and he gained a pretty morbid weight for 1 year. So since 2019 to 20, he remained absolutely fine with antibiotic for 3 months and gluten-free diet. However, in 2020, he started taking general food. He started taking wheat, chapatis, and other food that potentially contains gluten. Still, he remains well, and his weight gain that was achieved in initial first year remains static. But in 2021, this year in January, he has recurrent some symptoms, but he denies any aggravating factor for this. In personal history, as I said, he is most of the times away from home. He consumes meal from the hotel. How he has no high risk behavior for steroids. He is not an alcohol consumer, neither is a smoker. Now, to summarize the history, a young male without any prior comorbidities, presenting with a 4-year history of progressive large volume watery diarrhea, associated with colicky, pain abdomen, and significant loss of weight.
Okay, thank you, Dr. Mukesh, for that nice presentation. But I would like to have certain clarification on history. How was the onset? You said the illness is for the last 5 years. So I presume that it started in 2016. How was the onset? Was it just an abrupt disease or a very insidious disease?
Sir, yes, sir. It was an abrupt onset. Because he was fine, and one day he started having loose stools.
Okay. So the onset was abrupt. Okay. And then it lasted for a couple of weeks. Second thing, you said there's a weight loss in the first 5 months. He lost weight in the first 5 months and subsequently regained it. But now from 2020 or 21 beginning, he is having again problems. So is there any recurrence of the weight loss? Is he losing weight now or is it remaining static?
Yes, sir. He's losing weight. Every time he has diarrhea, he starts to lose weight, but his appetite is preserved. So when we took history, a couple of days back only, he had loss of weight.
Okay, so recently he has again weight loss. Okay, now from 2016 to 2019, when he took a gluten-free diet and tinidazole, did he go to hospital and get any sort of treatment or any evaluation done?
No, sir. Actually, yes, he was evaluated. That will come subsequently in this investigation part.
We don't want it now. I just want to know. And each episode, ever since the onset of diarrhea till he took a gluten diet and tinidazole, was it a continuous sort of thing or an intermittent diarrhea which lasts for a couple of weeks and then settles down and again comes back after a couple of days?
So it is a continuous type of diarrhea. Diarrhea remains on every single day. But when he used to take antibiotics that used to subside for 15-20 days, only to come back again. And when he was treated with tinidazole and cotrimoxazole along with gluten-free diet in 2019, he remained fine for a couple of years. Then again,
okay, thank you. Over to other faculty members.
Dr. Ramakrishna has a point to make, and then we ask them to interpret the case.
Yeah, no, I think that's a nice presentation. So I think some of the things that you talked about, and this is a guy who has a touring job. He is out of home a lot of time. So history of, you have talked about a history of extramarital relationships, which he doesn't have, which I think is very important in a setting like this. Somebody with chronic diarrhea who is from a relatively rural area. The one thing which is very curious is that why was tinidazole and cotrimoxazole given for 3 months? And was he investigated prior to that? I think Dr. Varghese has asked that. That could be a significant clue to the etiology of his problems.
Yes, actually, yes, he was investigated from 2017 onward as well. But he says he when he used to take antibiotics, that I presumably was flagyl. He says we used to take flagyl and the diarrhea could subside for a couple of weeks as well. So, but it could keep on recurring after that only. So the other investigation that was done in between will come in investigation part. So there must have been a strong point favoring starting these antibiotics.
I'm sorry, it wasn't clear to me whether the 3 months was a continuous 3 months of cotrimoxazole and tinidazole.
Yes, sir.
That's a rather strange combination of medicines to give, and so there must have been a reason for that.
Right, sir. He says.
Okay, and we'll come to that in the discussion. Yeah.
The co-chair makes points.
Dr. Mukesh, you summarized that he had colicky pain abdomen, but you didn't describe it exactly.
Yes, sir. I would like to explain this. His pain is not of an obstructive type. His pain is a colicky pain that improves after passing stool. And he never had a frank episode of obstruction leading to distension, recurrent vomiting, or inability to pass farts or stool. So by history, it appears that the pain is colicky in nature, that is for propelling the amount of stool or the liquid that is present inside the gut.
So every stool is preceded by this pain. Is it discomfort or pain?
Sir, he has pain, sir. He says there is cramp, there's spasm, then he runs to stool, and then it gets relieved.
Okay, and is there bloating, distension, borborygmi?
Borborygmi,
yes, there is gurgling sound, he says, but no significant bloating. But I presume most of us have some amount of bloating, but that is not to that extent that he could bring it into his complaints. So he has gurgling sound, he has borborygmi, but no significant bloating in sense.
And any history of other comorbidities and drugs for that, pain, headache, backache, NSAIDs, or any herbal drugs? That would be important. You know, the detailed history of drug intake. If a person is with 3 years getting flagyl and a combination of cotrimoxazole, so I would believe that the treatment is not exactly rational, and you need to elaborate on the history of drugs received, allopathic as well as herbal.
I guess, sir, he does not have any pre-comorbidities. For that, he took medicine. He became symptomatic only for this diarrhea. Otherwise, he used to be absolutely fine. He was very active man, what he says. And medications he took was only for this diarrhea, which most of the time was flagyl. This is metronidazole, and till he says flagyl, that is metronidazole, and rifaximin as well. But he said there was no improvement with rifaximin. He took wherever he went, he was prescribed rifaximin short courses of 2 to 4 weeks.
Can you go to our interpretation of findings now? Because we have to look, how do you interpret?
So Govind, is he going to just summarize in a word and say what it is, or
interpret the
we go to the findings now? Okay, fine. Physical findings.
Interpret the
Interpretation. Symptoms.
Yes.
Right, sir. We have that in subsequent slides. So I would like to invite Samagra, my colleague, for the further proceedings.
No, can you make a sort of a syndromic diagnosis as to what the etiology is,
Yes, sir.
and
Yes, sir.
then
Yes, sir.
tell us the possible or probable differential diagnosis at this point?
He's coming to it, so he's coming to it.
Okay.
So are you interpreting now, after the clinical case, after the summary, you interpret each symptom and try and learn from each symptom where the disease in small or large intestine. Is it a mucosal disease? Is it a luminal disease? It is a hormone secretion? What it is?
Sir, with this history and without examination, what we can make out of these symptoms is he has large volume watery diarrhea that seems to be organic because a significant loss of weight and nocturnal symptoms. So definitely his organic diarrhea, and definitely it's a large volume, high frequency diarrhea, watery stool. So as we heard you speak, it is most likely secretory type of diarrhea originating from the small bowel, sir. At this point, and yes, significant amount of malabsorption that he has, weight loss that correlates with the episodes of diarrhea. So weight loss is mostly because of diarrhea itself. So there is a malabsorption as well. So secretory type of diarrhea with malabsorption, probably the source lies in the small intestine.
Can I make a comment here?
Yes, sir.
Yeah. So I think in addition to the types of diarrhea, which you said you distinguish between functional and organic, and you distinguish between large bowel and small bowel, and the third is that you distinguish between fatty, secretory, and inflammatory. All right. So which of these three would you think this falls into? Is it fatty, secretory, or inflammatory?
So this is secretory type of diarrhea because.
Why do you say it's not? Why do you say it's secretory? I mean, I would say it's inflammatory.
Secretory because the characteristic of stool and the frequency and volume is so, as well as for inflammatory type, we don't have blood in stool. There is no arthropathies or no fever. These symptoms are absent, so it's more likely to be secretory rather than inflammatory. And yes, he has no fat, though fat droplets are seen only in extreme of the spectrum, but other thing lies, sir.
No, so Mukesh, so inflammatory is not necessarily to be confused with large intestinal. It can be small bowel also.
Yes.
And so if there's colicky pain abdomen, to me, that introduces an element of inflammation.
Right.
And I'll join issues here to some extent. You know, the classification is watery, fatty, and inflammatory. Secretory and osmotic are two different aspects of pathophysiology. One should not bring them here. Yeah. And most diarrheas, except for pure osmotic, are a mixture of the two. So let us not bring in osmotic and secretory here. Let us talk about the three. And yes, inflammatory can be small bowel as well. So it cannot be said that inflammatory will be large bowel.
Mukesh, can you go back to your slide? Let us first slide of your symptom, which is the most important slide, which tells you the diagnosis. If we read the summary of it, it says that large volume. It means whatever pathophysiology is there in the intestine is secreting large volume. Large volume can be because of malabsorption, can be because of water secretion. The two pathophysiology, like the coach said, osmotic or secretory nature. Second would be that jets of water volume. So it means the large volume is coming to large, from small intestine to large intestine. Now, large intestine is not able to retain it because of increased motility there, or the volume is too large for colon to get absorbed. And therefore, and there's urgency. What is urgency? Urgency means large amount of water has come to the rectum. Water stool has come to rectum, and rectum can't hold it. If you can't hold it, it'll say severe signals to rectal contraction to the brain and then efflux. And then you have urgency. You have to pass through by it simply means the large volume of stool content is being released into large intestine, coming to rectum responds to large volume and leads to urgency.
I think, yeah, that is one way to look at it. I would not totally exclude colon pathology here. Large volume of watery content coming into the colon should be absorbed. So I would feel that the colon salvage is not totally functional. So there could be, unless there is motility problem, which will again suggest an inflammation of the colon. So I would say that you cannot exclude right side, particularly the right side of the colon as not being involved. I would at this moment keep small bowel diarrhea, not excluding colonic component in the pathogenesis.
Absolutely, sir. Absolutely. And one other point was that when there's large volume of water in the small intestine or large intestine, the intestine will always contract to lead to efflux, and therefore there will be pain abdomen.
Yes.
So this pain, which takes along with this, it tells you whatever pathophysiology is there, the large amount of water is secreted in the small or large intestine, and large intestine is responding to that and leading to pain abdomen. So this is what pathophysiology is in this individual.
Can I make a point?
But before you make that couple of questions, which just take a few questions from chat box, which the Alok has asked one question. No, let me take a question of Prakriti. Prakriti asked that how do we define small and large intestine diarrhea? Now, what to ask the patient? Prakriti, that what Mukesh also said, and I said in my presentation, that small intestine, large intestine has some specific characteristics. Small intestine, if there's a diffuse disease, like mucosal malabsorption, therefore the volume may be large. Small intestine, the volume may not always be large because most volume is being absorbed in the large intestine. Second, if you have blood in the stool or mucosal pus in the stool, it tells you that it is rectum is involved and inflamed. IBS patients do also have a large bowel diarrhea, but they don't have mucosal break, therefore they don't have bleeding. But more frequency tells you that it could be a large intestinal disease. Yes, Dr. Varghese.
Professor Makaria, in one of the sessions, one student asked me, what is the quantification above which volume you call it large volume and above certain volume we call it small volume. And I could not find any reference in the textbook apart from a vague mention in Susinga, which says that approximately 1 liter may be the cutoff between small and large volume. Is there any highlights on that particular aspect? Because that question also, how do we define small versus large volume?
I think this is I think taking clinical medicine to depth, and so there's no definition. There cannot be any definition. There cannot be any definition of a volume cutoff. There cannot be because the etiology would be different of large and small intestine. It's just about small and large, but 1 liter certainly not, because most even those patients have diffuse mucosal disease, like for example celiac disease or tropical flu, will not have a 1 liter. 1 liter is a volume described for secretive form of diarrhea, where large amount of water is secreted in the small and large intestine. That's defined for secretive, but not for small and large intestine. I think we have to take all these things into context, defining small and large intestine rather than the volume only. And let's not go too much of depth to all the questions were there. Let's not go too much of depth. There are all those clinical pointers that you combine all of them together. You give you a pattern. It's not a diagnosis. Give you a pattern of small or large intestine. We cannot be defined on one single point. It's about all of 3-4 points gives an idea that this is a pattern of large intestine type.
What I felt that when such a patient is admitted into the hospital, perhaps we may be able to quantify it. Till then, we have to believe the words of the patient. When a patient is admitted and evaluated for chronic diarrhea, perhaps we can really collect the stools on a 24-hour basis and perhaps have an assessment of the volume. Till then, we have to believe the words of the patient. That's what I.
2 other questions come from audience. One is Alok, who asked very pertinent question. And I think we should take these questions now. Why blood is not a feature of small intestinal or inflammatory disease? Alok, you are right that any small intestinal disease like Crohn's disease or tuberculosis will lead to blood in the small intestine. But this blood may not be visible to patient because the amount of blood which is secreted in the small intestine or large intestine, unless it's large in volume, this will not be visible to patient. Just take an example, hemorrhoids, even one drop of blood is visible to patient. Therefore, patient always complains blood in the stool. Ulcerative colitis, there's a blood in the rectum, therefore there's a bleeding. Patient always knows there's a blood in the stool. But all small intestine disease or right side of large intestine disease can still bleed. Blood is not visible to patient. Therefore, patient will not come to you with this unless you do a full blood test. And
okay, I will supplement it by saying that the blood actually is there, but it is diluted. It is diluted so that the patient is not able to see it as blood because of the volume is large.
And second question again, Sanchit has asked that should we commit, as the coach said, should we commit the diarrhea secretory, watery or fatty or inflammatory? I think all the textbook and the Yamada or Schlesinger, they define diarrhea into inflammatory, fatty or watery. In clinical practice, it's very difficult to differentiate. And in clinical practice, probably it's the more important the content of stool. Fatty means you're talking about small intestine disease. But again, I can't get this by history. Unless you do a stool fat, you would never know, unless the stool fat is too large in the stool, the patient can see as a greasy stool or stool which sticks in the pan, we cannot say that. And in small intestine disease, there won't be fatty diarrhea. So I think we should keep away from these three questions of fatty, watery, or inflammatory in the description.
I think this difference is after the initial evaluation of this tool. Without a laboratory examination of this tool, it will not be really possible to say it is inflammatory or fatty. So actually, Schlesinger says it very clearly. After analysis of this tool, it may be divided into fatty or inflammatory. So I think it's not a clinical differentiation.
I think I'll just add a bit. You know, for 1970s to 2000, we just talked of small bowel, large bowel diarrhea. The pediatrics people were always talking of these three distinctions: fatty diarrhea, watery diarrhea, and inflammatory diarrhea. And we used to criticize them for, trying to split here. But somehow this has crept into our textbooks also. And if the examiner says, what is the type of diarrhea your patient has? Then that is the question. You say fatty, you can probably still say that the hands become greasy or there is fat droplets visibly seen in a small minority, but you can still say that. Now, watery is watery. Inflammatory is the question. Now, the diarrhea which is inflammatory, the stool which is inflammatory should have mucus or blood, or you have inflammatory symptoms. So we are talking of diarrhea only. So diarrhea inflammatory means if you have pus cells, if you have blood, if you have mucus. So Thomas is absolutely right that this comes after initial examination of the stools. But if the examiner wants the candidate to commit, then fatty diarrhea can be committed, present or absent, or unequivocal. Watery diarrhea can be certainly committed. Inflammatory only if there is, pus or mucus, then or blood, then you can say. Otherwise, you say that I cannot differentiate. So I believe that most examiners will today like to question the resident, what is the type of diarrhea in your patient? So you have to be very diplomatic in answering this question.
So moving from there, I think we go to the Samagr would like to give us a clinical diagnosis based upon what we discussed. And also this is very important for all of us to really understand each symptom. As we see each symptom, we keep interpreting our mind that where the disease lies, be it small intestine, large intestine, or any other organ. So Samagr, can you give us a differential now? Discuss this case further and give a differential.
Mukesh, can you stop sharing the screen? So good afternoon, everyone. My job has been made easier to a lot of extent because a lot of the discussion
some of you wanted to know your clinical possibilities before we go to clinical examination.
Yes, sir. As Makharia sir pointed out earlier in his talk, we always have to analyze the symptom that is present. In this case, diarrhea appears to be the predominant symptom. And whenever we have diarrhea, it is very important to answer these 7 questions that help us in arriving at a differential diagnosis. Do we have acute or chronic diarrhea? Is the diarrhea functional or organic? Do we have a small bowel or large bowel involvement? Is there significant malabsorption? Is there obstructive pain or non-obstructive pain? Is the diarrhea associated with bleeding? Is it inflammatory or non-inflammatory? Or if we can make out any feature suggestive of osmotic, secretory, or dysmotility related diarrhea. So first, very simple question, but it is very important, especially in OPD practice. Are we dealing with functional or organic diarrhea? In this case, we have no blood. So that probably is in favor of functional diarrhea. However, we have a significant nocturnal frequency to the extent that the patient is having nocturnal incontinence. We have definite weight loss, which the patient had documented, and the patient is passing large volume of stools. All of these features favor organic diarrhea. And in this case, we definitely are dealing with a case of organic diarrhea. Next question comes is it a large bowel or a small bowel involvement? As the discussion till now has clarified, when we talk of large bowel, we are mainly talking about the rectum, involvement of the rectum, rather than involvement of the whole of colon. And as Kocha sir pointed out, involvement of the proximal colon can also have features of small bowel diarrhea. Nevertheless, we still make that distinction because it is clinically relevant to our workup, and it gives us some idea how to proceed further. So in this case, small bowel diarrhea has a usually large stool volume which is present, and rectal symptoms in the form of tenesmus, urgency are usually present, which are absent in our case, or at least they are not very prominent. Steatorrhea, excessive flatulence, and protein malabsorption will point towards a small bowel cause. And we do have features of borborygmy, but the patient does not complain of excessive flatulence. So we cannot comment on these points. Pain abdomen is an interesting point. In patients with the small bowel diarrhea, the pain is described as central abdominal, and which usually might not improve with defecation. In our case, the patient complains of pain which improves with defecation. So it has features of both small bowel and large bowel involvement. So considering all these points, I would still like to commit to a small bowel type of diarrhea. But again, we can't, when we say small bowel, we cannot rule out involvement of proximal colon. The next question is again interesting: is malabsorption present? We have a significant weight loss in absence of any inflammatory symptoms, and the patient has a low BMI. We haven't come to the examination, but and the patient complains of gurgling bowel sounds and colicky pain, which are characteristically associated with carbohydrate malabsorption, in which the carbohydrate might be fermented, and it might increase the volume of the water in the bowel, and that might contribute to these symptoms. We again haven't discussed the examination, and we did not we did not see any signs of micronutrient deficiency or pallor. So all over this suggests that the patient does have malabsorption to the extent we can identify clinically. So coming back to our symptom analysis, we have a diarrhea of 4-year duration. So this is definitely chronic. We have established that it's organic diarrhea. We have also established that there is small bowel involvement with probably some proximal colonic involvement. There is definite malabsorption. We haven't come across any features of obstruction. So the diarrhea appears to be non-obstructive, even though the pain is present. There is no bleeding that the patient complains of. Based on our clinical symptoms alone, we cannot establish any features of inflammatory diarrhea, although Ramakrishna sir said that pain might be a feature of inflammatory diarrhea. So overall, I would still like to commit to a non-inflammatory diarrhea at present. And I cannot establish any features suggestive of osmotic diarrhea or any secretory or dysmotility features. But overall, considering that the patient is passing large volume of stools with a relatively high frequency, I would like to commit to a secretory cause of diarrhea. So overall, all these pointers point toward, so to summarize the case, what we have established clinically is a young male who has no significant comorbidities with no significant drug history other than antibiotics prescribed for diarrhea itself. And he has a chronic diarrhea of 4-year duration, which is progressively increasing, which is a large volume, which is associated with malabsorption and which does not have any clinically overt obstructive or inflammatory features. So my pathological diagnosis at this stage would be diffuse small bowel mucosal disease. The possible differentials that I would like to consider at this point would include tropical sprue, Crohn's disease, celiac disease, intestinal lymphangiectasia, certain immunodeficiency syndromes, or certain prolonged parasitic infections, and certainly bacterial overgrowth.
Discuss it wonderfully well. I just want to ask you, how strong is the suspicion of malabsorption in this patient? Because normally when somebody has malabsorption, you have features of carbohydrate malabsorption, protein malabsorption, fat malabsorption, then vitamin deficiencies, mineral deficiencies, so many things are there. So here the patient has got chronic watery diarrhea plus weight loss. And the only other thing perhaps is borborygmy. Is that sufficient enough to say that there is malabsorption?
Yes, sir. So, to my understanding, the malabsorption there's a spectrum of findings, and a lot of findings enter the clinical spectrum after a relatively long time. This patient has been partially treated. He has been admitted outside multiple times, and he might have received certain treatment that might have taken care of some of the features of malabsorption that have not become that overt as of this stage. But considering the fact that he has still lost weight.
Just in interest of time, just like add one word, because as Dr. Thomas said, the spectrum of malabsorption will vary. If it is severe malabsorption, we'll have all classical manifestations, like child A, child B, or child C cirrhosis. Child C cirrhosis have every feature of liver failure, but child A and child B has less number of feature liver failure. So always keep in mind that if disease is severely affecting the diffuse mucosa, then we will have more symptoms. If we have a mild disease, the symptom may not appear. And therefore, we know that patients with celiac disease do present with a functional bowel disease like IBS, because the symptoms are not that remarkable to present like a malabsorption. They present like a IBS. So we need to keep that in mind, that every patient may not have all the features of a particular disease. It's all about in a whole length of disease. I remember this straight line, and which I always tell, I've learned myself over time that every disease has to cross this line. And if patient, you may pick the patient here, early part of disease, you pick patient here, you pick patient at end of disease. If you see at the end of disease, patient will have most classical manifestation, most classical symptoms. But if you pick up a disease a year or two earlier, you may not have all classical manifestations. So that we need to keep in back of our mind that every patient may not have every feature of every disease.
Yes, I do agree. I do agree that there's it's a perfect spectrum. So I just want to say that patient also may reduce the intake of certain type of food. For example, they may stop milk intake completely. They may stop fat intake to a significant extent, and therefore they cannot manifest with steatorrhea. So sort of withdrawal from certain food by the patient or as advised by the physician or local doctor also may contribute to the symptomatology, lack of symptomatology, which we expect. So in this patient with significant weight loss, what do you think is the cause of weight loss in this patient? It is 70 kg. And if it is early in the evolution of malabsorption syndrome, how do you explain 20 kg weight loss? Do you think you have to bring in some other etiology which will produce chronic diarrhea and marked weight loss, in spite of the fact that he is a very decent gentleman?
I was going to add the same thing, that two striking things in this patient were chronic diarrhea and really significant weight loss. So you did talk of 15 to 20 kgs, but you could have told us the baseline weight also. In any case, you said that 15 to 20 for anyone would be really. So which of these conditions would account for that much of weight loss?
Sir, basically, a long-standing malabsorption that has been going on for approximately 4 years in any of these conditions can account for this degree of weight loss. Had he had
let's Dr. Mukesh, you have listed all these conditions. So tell us with each one of them.
Yes, tropical screw patients with tropical stool can have that much of weight loss.
How many tropical screw patients have you seen in last 3 years?
So very few. To be honest, very few.
Okay,
actually.
so just like that. Okay, so that keeps tropical screw aside, not on number 1. Right. Go to the next one.
Right. Crohn's disease, yes, they can have a significant loss of weight, sir. And we have seen a lot of cases of Crohn's disease.
Yes, Crohn's
But
disease.
pain.
Yes, 4 years diarrhea only. That means isolated small bowel Crohn's disease. So again, how many patients of Crohn's disease would have presented like this in last 3 years?
Diarrhea and with only diarrhea and significant loss of weight, very few, but yes.
Okay, so that also comes aside. So go to the next one.
Celiac disease, yes, many patients with loss of weight and growth retardation and all, but onset at this age and significant loss of weight right at the onset, very few, sir.
Okay, and in between he was well. He had stopped gluten and felt better.
But
do you get credence to that?
Yes, sir. At that time he was also started on tinidazole and cotrimoxazole. But after 1 year of asymptomatic period, he was started taking gluten-containing diets, but he did not have relapse of symptoms for next 1 year. So I think
I have to make a point out here that your observation that celiac presentation at this age, again, this is the point to understand that celiac disease or tropical screw can present at any point of time. Celiac disease growth retardation is not essential. It all depend upon at what age the disease severity is there. So those diseases which are very severe, they manifest in childhood, they have growth retardation. But they're also patient, we don't know why, but there is a second hit. The first hit is the genetic and wheat intake. The second hit may be viral, which leads to enteropathy, and that just precipitates the manifestations. And therefore, a lot of people call it adult onset celiac disease. It's not onset, it's a manifestation seen in adults, so can occur. And celiac have been diagnosed for the first time at age of 60 years. It also applies to Crohn's disease. You can diagnose Crohn's for the very first time at 60 years of age or 70 years of age. So these points probably are not very strong point. You should argue on the point which are more tenable. So age-based diagnosis, gender-based diagnosis are not a strong point you like to consider while ruling out or making a diagnosis. They are supportive points.
Dr. Mukesh, can you still consider celiac and wriggle out of the situation? Because yes, is there any situation in celiac where this sort of scenario can happen?
Yes, sir. Like Makharya said, there can be adult onset or even elderly old as 60 years. But sir,
no, for the argument's sake, I agree that this is celiac disease. My question is that, in spite of adhering to gluten-free diet for the last 1 year, still he has developed diarrhea and weight loss. So, how do you explain that? Or what are the scenario in which a person apparently taking gluten-free diet continues to have symptoms in a celiac disease? That's the issue.
Yes, sir. Actually, they can be refractory celiac, but most of the time patients are not exclusively on gluten-free diet because there are other diets and commercial food.
No, he may think that he is perhaps taking gluten-free diet and probably it is not really gluten-free. That is one possibility. Right. Or it may be non-responsive gluten disease, or he may have an underlying malignancy. Okay, that may be the reason why he is not responding.
Well, the last point before we go to examination, I just want to make that if you look at pathophysiology of any of the diseases you described here, that here's a large volume watery diarrhea, right? Here's pain abdomen. So how does Crohn's disease will lead to large volume watery diarrhea. What would be pathophysiology of that? In Crohn's disease, you have ulcerations, 1 ulcers, 2 ulcers, 10 ulcers, 20 ulcers, diffuse ulcers. These ulcers will exude the content, either because of diffuse malabsorption, because of mucosal replacement by ulcers, or by secretion from the ulcer base, like proteins and like a protein-losing kind of a scenario. So that will not lead to watery form of diarrhea. What drives water in the small or large intestine is the question here. So in tropical sprue also the question comes in more of a content. It's not watery. If your stool is watery, how does a watery stool occurs in tropical sprue? How does watery stool occurs in celiac disease or Crohn's disease? Its content is water, from where water is driving into the intestine, and which colon is not able to absorb and allow it to pass through the rectum. So would you think more than that? Some form of what drives water in the colon or small intestine? It's only diffused because of disease by tropical celiac or giardia or what number of disease you enumerated. But does it make you happy that what's happening really? Everywhere, all disease, there's a mucosa is replaced by some disease, but from where water is coming?
Okay, Dr. Mukesh, you thrash out your remaining diagnosis and then we'll continue the discussion. Professor Rama wants to say something, no?
No. All I was going to say was that malabsorbed fat by itself drives water secretion from the colon.
True.
So, on that one point, I would not necessarily. I mean, this has been shown time and again that hydroxy fatty acids, unsaturated fatty acids, drive secretory diarrhea or water secretion in the colon. And the only comment I'll make to Mukesh is, which I think you've already made, is that you have to arrange you're given a range of diagnoses. I completely agree with these, but you have to arrange it in the chances of likelihood. Which do you think is first is what should come first, and what you think is less likely should come towards the last. I don't know if this is arranged in what you think is the most likely way.
Yes, sir. Yes, I totally agree with this, but we have just put our differentials actually.
Okay, there's a question by Dr. Rajender and Dr. Matri that would you consider HIV related diarrhea in these patients?
Immunodeficiency is mentioned.
But you also like to consider, maybe keep it primary and secondary.
Yeah, HIV, I think even if the patient says that, the patient always can deny high-risk behavior, especially when asked publicly in front of others and all. So I think in a chronic diarrhea, weight loss, HIV has to be there. It has to be always ruled out. It's a must.
Okay.
That's what I say.
Let's go to the clinical.
It's already mentioned there in immunodeficiency. So it's acquired immunodeficiency. So it's already there.
Yes.
Yes, sir.
Can you go to clinical examination now and interest of time, and then we'll come back to diagnosis?
Yes, sir. So the examination in this setting mainly helps us to establish the severity of malabsorption. And in addition to that, it also might provide us certain clinical clues that might help us to get closer to the diagnosis. So in our case, the patient was fully conscious and cooperative. He had blood pressure on the lower side, but still in the normal range. He had no tachycardia, respiratory rate was normal. There was no pallor, icterus, cyanosis, or edema. But important point was that clubbing was present. In anthropometry, the patient had a low BMI. BMI was 17.2 kg per meter square. And we could not make out any signs of micronutrient deficiency on general physical examination. Systemic examination was also normal. He had a normal per abdominal examination. The respiratory system was normal. Cardiovascular system and nervous system examination was all normal. So the only two more positive findings, let's say, that we got from the general physical examination was that clubbing was present and the patient had low BMI.
Dr. Samagra, in a patient with a chronic diarrhea and suspected malabsorption, can you just enumerate the items which you look from head to foot, from the hair to the toenails, what are the things which you normally look for? And even if it is you say no, but this is irrelevant because you said signs of micronutrient deficiency and signs of calorie deprivation, all those things. No? So, but for the benefit of all the others who are listening this program, can you enumerate the various signs you may look for from head to foot in a patient on dental examination?
So we can divide them into signs of macronutrient deficiency and micronutrient deficiency. When we talk about macronutrients, we are essentially looking at certain anthropometric measures. We can look at BMI. We can also look at triceps skin fold thickness, mid-arm muscle circumference that can help us establish the severity of fat and protein loss respectively. However, those are not very routinely done. When we come to micronutrient deficiencies, we are looking at water-soluble and fat-soluble vitamins. Among fat-soluble vitamins, we can look for vitamin A deficiency. The patient in history might complain of night blindness. On an examination, we might find xerophthalmia, Bitot spots. In vitamin D deficiency is usually asymptomatic. However, if it established at an early age, we might find some bony abnormalities. Vitamin K deficiency might present with easy bruisability and bleeding from the gums. Then we can have water-soluble vitamin deficiencies. Vitamin B1 deficiency can present with the dry or wet beriberi that are classically described. Dry beriberi will have more of neuropathic signs. Wet beriberi will have more of cardiac failure, high output cardiac failure. Vitamin B2 deficiency present with perioral signs in the form of chelosis and angular stomatitis. B3 deficiency presents with classical pellagra, which is classically described in form of 3Ds, dementia, diarrhea, and skin rash. Then we can have vitamin B12 deficiency, which can present with either anemia or it can present with in certain forms of neuropathy in the form of spinal cord involvement. Then we can also have certain mineral deficiencies in the form of iron deficiencies, selenium deficiencies. Those are relatively rare and relatively hard to make out on clinical examination alone.
But apart from nutrient deficiency, you should also look for other telltale signs of other diseases like pigmentation in Addison's disease, pigmentation in tropical screw, then skin manifestation or additional skin manifestation, which you may get in diseases. No, the disease-specific symptoms or signs also may be there on the skin. So general examination has to be thorough in a patient with chronic diarrhea and malabsorption. That's the point which I wanted to tell everyone.
Okay, sir.
Okay, let's go further now. How do you knit up the history and the physical findings?
There is one prominent physical finding, clubbing. So which is this chronic diarrhea where clubbing is a significant finding. We have a clue now.
Sir, immunoipsid can have prominent clubbing. However, a certain degree of clubbing has been described in other forms of malabsorption as well. So it points towards essentially what we can say is that points towards a chronic disease, but we can't base our whole diagnosis on a rare diagnosis on just one physical finding.
So even if celiac and tropical and lymphoma, if it have a very significant clubbing, if it is a very prominent clubbing, I think you will have to think of lymphoma. All other conditions, you have a minor or a mild form of clubbing. That's the difference.
I think if you go back to that differential diagnosis list, can we go back again?
Yes, sir.
It is forward. Yeah.
So you look at tropical screw, we had virtually excluded. Crohn's disease, I would have kept it because of large bowel component. Celiac was unlikely. Lymphangiectasia, how had you kept it?
We had mainly considered features, diseases that are present with diffuse small bowel mucosal involvement.
No, but there are telltale features of lymphangiectasia. There's heavy protein loss, there's ascites, there's pedal edema. There has to be something to suggest lymphangiectasia to keep it. Otherwise, why have you not kept, for example, A-beta lipoproteinemia or Whipple's disease? I mean, you keep the differential diagnosis considering something there, some pointer.
Yes, intestinal lymphangiectasia to present at the age of 32 also is very unlikely.
Yes. So, I mean, this point was raised earlier also, that the possible differential have to be in the light of probability in a particular order rather than just enumerating the conditions.
And why is important, Samagra and Mukesh and all of you, that based upon the clinical differential, you are going to order investigation, right? And in that case, I must know as a clinician treating patient that what test do I do which have the highest probability of.
Okay, so now coming back again, so you have malabsorption, you have chronic diarrhea with weight loss and clubbing. I would say that pain, I was not ready to buy that pain is just because of diarrhea. I would not still buy that pain is due to diarrhea. Celiac disease, whatever, I have never seen with pain unless there's a complication. Tropical screw, again, pain is not there. And giardiasis, no pain, bacterial overgrowth, unless there is blind loop syndrome or strictures, basically. Parasitic infestations like giardiasis, no. Immunodeficiency, you have to have the whole gamut of symptomatology. IPSID, yes. Crohn's disease, yes. Any condition interrupting the motility, you can have pain. So that I would have felt it slightly differently on your interpretation of pain. But anyway, you go forward.
I had one question, sir. Can we consider, for the examination point of view, at least, can we consider a rare diagnosis as a first differential, especially when we do not see it that frequently? Even if other diagnoses which are more common, but rarer presentations of those diseases can be still there.
You mean like in this case, could you have considered IPSID as number one?
Yes, that is my question. Yes.
Yes, I would have said celiac disease number 1, Crohn's disease number 2, IPSID number 3.
Okay.
Because of celiac is the commonest in this part of the world. Crohn's disease could have explained everything, including the pain. And IPSID again because of pain. And if you have clubbing, it adds to it very, very strong.
May I comment on that?
Yeah, please, Dr.
So
Ram.
this man is from West Champaran district in Bengal, where celiac disease is not that common. I would actually put parasitic infections up on top. I mean, Crohn's, celiac, we could consider IPSID, yes, because he's younger age and the clubbing. IPSID would be stronger if you were able to palpate a mass in the abdomen.
Yes.
Yeah. So, but I do agree with your general trend, except for celiac. Celiac and its complications, certainly, yes, to be considered. But probably, since he's from Bengal, probably
maybe
not right
that factor could be, yes. In the, I would say, Hindi-speaking belt, as you are part of that work, that celiac is all over now.
Yeah.
I have a question. Actually, he belongs to West Champaran, that is in Bihar. But most of the time, he is touring all over the India to audit the energy consumption. So, in that scenario, whether to attribute diarrhea to such some conditions that are more prevalent in Bihar, or to take consideration should he travel to all part of India?
Anyway, traveler's diarrhea will not be like this. For 4 years with okay, we have to thank you. We have not covered parasitic infestation. Professor Kocha, do we have to mention at least the name of the parasitic infestation which will produce a chronic recurrent diarrhea and weight loss? Can we complete that and then proceed?
Yes, Samagra has the list.
Yes, sir. A certain number of parasites, especially in a certain limited kind of immunocompromise, can cause chronic diarrhea. Chronic giardiasis has been described in certain renal transplant patients, especially in post-transplant setting, and selective immunodeficiencies. Strongyloides has been described, and then we can also have some rarer parasitic infections that include microsporidia. which can be present. However, again, considering all these, I would still not keep it in my first differential, considering the case that we have presented.
Which are the most prominent parasites causing malabsorption?
Sir, giardiasis and strongyloides, probably.
Okay, and some which we don't see in generally don't see in India.
So,
So can I come in here again?
Yes, yes.
So coccidial infections, which are intraepithelial parasites in the small intestine, we see them, of course, more in patients with immunodeficiencies, but we do see them as causes of chronic diarrhea in patients without significant immunodeficiency. So these would include things like Cryptosporidium, obviously, and Isospora pelli, and what are now classified as fungal infections, which are the microsporidiosis.
Yes.
And often the diagnosis is difficult because our investigations are not geared to that.
Yes, that is true. Primarily in immunodeficient, yes, and as you say, maybe in non-immunodeficient also. The parasite I was referring to is that Diphyllobothrium latum.
Latum, which is in Finland.
Yes, so that is to complete the list, that if you could talk of Whipple's disease or a beta lipoproteinemia, we could talk of that also to, make the list ready for all the students.
There's a good list of things in Schlesinger, including Capillaria philippinensis.
Capillaria, yes.
Yeah. Okay. I think I also agree with Professor Kochar that my differential diagnosis would be an atypical celiac. Then again, Crohn's with some atypicality, IPSID. Still, I am not, I don't want to rule out immunodeficiency syndrome, either acquired or congenital, because the symptomatology is strongly in favor of this weight loss. I am very much concerned.
It's interesting that TB did not make it to this list.
We have already reached.
Always considered as a differential diagnosis for Crohn's.
For the information of everyone, we have reached 12:52. As per the allotted timing, we have only 8 minutes. Professor Makaria may give us another 15 minutes. So can we proceed further?
Varghese,
yes.
The question asked is, one of the participants asked, wanted tuberculosis. Just to close the answer to that, for diarrhea to occur, we need to have a large segment of intestine to affect it. Tuberculosis is generally a unifocal disease and it's only a small segment of a small and large intestine. Therefore, diarrhea is not a very important differential. Tuberculosis is not an important differential in this kind of diarrhea, which is a more watery, more large volume. So if at all diarrhea will occur in tuberculosis, it is more of a SIBO types rather than of a malabsorptive type. Therefore, tuberculosis has not been kept. Although some patient tuberculosis is also could be diffuse involvement, but there are only few. Therefore, TB is not important differential. Can we go to
about eosinophilic enteritis? No, there's a question about eosinophilic enteritis. Can it be considered?
Absolutely.
I think a pain also will be a dominant manifestation. I think it comes in the immediate differential diagnosis of Crohn's disease. Most of the features are similar. I think pain is a dominant manifestation of that condition also. So if you keep Crohn's low in the list, then eosinophilic also.
And normally we would have, yes, just a one word only, that with IPSID we have to keep diffuse intestinal lymphoma also. IPSID is a very, very specific thing, and as Samagra had asked that, can you keep IPSID as number one?
It is no, never sir, because it is a rare thing in our country.
Yes, so but lymphoma can figure in reasonably high up in any differential diagnosis of chronic diarrhea with such significant weight loss.
Yes,
I want to make one point out here that I just said that you make a diagnosis based upon the commonality of things. That's a wonderful thing to do. But we as a specialist, we are tertiary care center. and all of the gastroenterologists will be at tertiary care and in big and be a tertiary care center. So this analogy of common disease occurs commonly may not always apply to us. So we need to keep, if the signs and symptoms are suggestive of particular disease, even if they're rare, we need to think of. If there's no specific point to go to an uncommon disease, is fine. But if there are specific signs, even if it's uncommon, this could be only one diagnosis in a given patient. I mean, we need to, because we are a tertiary care center, we are not at a primary care center. Right. With this, can you go to how do we investigate this patient? And we have now time left is almost 10 to 15 minutes. So let's go quickly.
So should I just briefly summarize the investigations and so that in the interest of time?
So what do you want? What are your principles of invest? What kind of principles?
Yes, sir. So I would like to divide my investigative workup into two arms. One would be to establish the etiology of malabsorption and diarrhea. And the second would be to establish the severity of malabsorption and diarrhea in this case. The severity, establishing severity is important because of the fact that most of our management will be directed based on how severe malabsorption we have got. So for establishing whether or not malabsorption is present and the severity of malabsorption, we start with routine blood parameters like complete blood count with a peripheral smear, LFT, KFT, and along with that, then we would like to go to some stool examination to establish that how much of the malabsorption is occurring, and then we can also have some etiological workup that goes along with it. We can do serum markers for celiac disease like IgA-TTG. We can do immunoglobulin profile to assess whether the patient has any selective immunoglobulin deficiency. We can also do a stool workup for atypical parasites, including stool antigen. Then following that, we would like to move on to, if none of this workup helps us point to a certain direction, we would like to move on to endoscopic evaluation. We would first do a upper GI endoscopy and a duodenal biopsy, and along with that, colonoscopy. And if we find any pathology in the ileum, we can go for ileal biopsies and colonic biopsies as well. Based on that, that will help us plan further workup, and then we can go ahead and decide whether we should go with more selective tests. I have not covered HIV workup has also.
Imaging you have not covered yet.
Yes, sir.
Please continue. Imaging is an important investigation.
Yes, sir. Imaging, if in this case will help us rule out certain stricturing diseases of the bowel, and will also in certain cases give us certain pathological findings, like if the whole bowel is diffusely inflamed, if there is diffuse involvement of the bowel, or if there is diffuse infiltration and edema of the bowel, that can be identified in this case.
Plus pancreas.
Yes, sir. Pancreas can also be involved in these cases.
So let us see the investigations in that order.
Yes, sir. Sir, so we have serial hemograms. The patient has been evaluated multiple times over the past 4 years, and we can see that the hemoglobin has been essentially normal, and there has been a slight reduction in platelet count over the past 4 years. Peripheral smear showed normocytic, normochromic RBC, and TLC was also adequate with no atypical cells. If we look at the liver and renal function tests, the renal function tests are normal with a normal sodium and potassium. However, one interesting finding is that the patient has persistently low globulin. Now, this low globulin could be a part of malabsorption, or it could also be a part of primary disease. In the sense, the patient might have selective immunoglobulin deficiencies. Then we come to basic etiological workup. We did IgA-TTG was done multiple times, and both of the times it was negative. HLA genotyping was also done, and it was HLA DQ2 was positive. Stool routine has been examined multiple times, which did not show any ova, cyst, or acid-fast bacilli. Giardia and Cryptosporidium antigen were also negative. However, a jejunal aspirate was done once in 2019 that showed MDR pseudomonas. I'm not sure of the significance of that, and that could very well be a contaminant in that setting. Anti-HIV has been done multiple times, and it has always been negative. However, something that is interesting is the immunoglobulin profile, which has also been done multiple times. And IgA has been deficient on 2 of the occasions, and IgM has been deficient on multiple occasions. And IgG also has been deficient on both the occasions when it has been measured. So this immunoglobulin profile certainly points towards immunodeficiency. Whether it is primary or secondary will again require certain investigations. Upper GI endoscopy has also been done multiple times, and it was essentially normal except for last upper GI endoscopy that was done here that showed small nodular lesions in duodenal mucosa. I'm not sure if they are very evident, but this is they have some small nodules are present in the duodenum, and multiple duodenal biopsies have also been done, including one jejunal biopsy in 2019. Duodenal biopsies mainly showed one of them showed mildly flattened and blunted villi with crypt hyperplasia, and but a repeat biopsy showed largely maintained villus architecture. A jejunal biopsy showed focal neutrophilic infiltration with occasional cryptitis and normal crypt architecture. A duodenal biopsy that was then done in April 2021 showed mild lymphoplasmacytic inflammation with many pear-shaped trophozoites suggestive of giardia. Colonoscopy has also been done once. It was done in 2018. Showed only multiple small nodules.
Would you do colonoscopy in this patient? It was done for, let me skip. If you want to do, then let's consider, otherwise skip this. Because this will give a wrong connotation to all our participants that all investigations have been done indiscriminately. So let's skip this unless you want to do colonoscopy. Because let's not include those investigations which we don't want to do.
Yes, sir.
Otherwise, the wrong message going to all 400 participants out here.
Sure.
Mahendra, please don't show those investigations which are not relevant.
Probably this was done elsewhere. Okay, proceed, please.
Anyway, but this gives the wrong connotation to all our participants that every patient with chronic diarrhea should have both upper GI and lower GI colonoscopy, which is not justifiable.
Yes, sir. To establish the severity of malabsorption, we also a urine D-xylo test was also done in 2019, which showed low urine D-xylose levels. And we also have one imaging, multiple imaging done over the past few years, which showed essentially normal bowel with the multiple small mesenteric lymph nodes. So that essentially concludes the investigative workup that we have at this point.
So what is your final diagnosis?
Yes, sir. So to summarize the investigation.
You could go back to the previous one. You were showing yes.
Yes, sir. We have one report of CRP that was less than 0.3. TSH was normal. Lipid profile has been normal. Fecal calprotectin has been done 2 times, which is positive. This again is not very specific, but can indicate that a certain inflammation is going on in the bowel. Whether it is related to infection or inflammatory bowel disease, that is not clear at this point.
This cholesterol and triglycerides are low, 82 and 87.
Very low, very low.
So this would fit in.
In fact, which chronic diarrhea malabsorption have low cholesterol and triglyceride? I think when they lose it, how do they lose it? That happens in intestinal lymphangiectasia.
Also, you'll always keep a possibility of A beta.
Severe fat
A
malabsorption.
beta
Do we
hypoproteinemia.
have beta carotene levels?
We don't have beta carotene levels, sir.
Okay, and calcium and prothrombin time?
Yes, sir. Those were all
Normal.
Normal, sir. Calcium was 8.2, which was on slightly lower side, but
and he had a unusually high hemoglobin all the while. It's 16, 17 grams to start with.
yes, sir.
18 in fact. So any cause for that? 18 is rather high. Do we have the PCV?
Sir, we had a full peripheral smear done. The PCV was normal.
Okay.
So, Dr. Samagra, please summarize the abnormal findings on lab.
Yes, sir. So to summarize the investigations, we have multiple investigations done over the past 4 years, and there is persistent hypoglobulinemia, and all globulin fractions are in fact low. We have documented lymphoid hyperplasia in form of histopathology from duodenum, jejunum, ileum, as well as mesenteric lymphadenopathy visible on imaging. And we have documented recurrent GI infections. We have one jejunal aspirate that showed MDR pseudomonas, and then we have giardia documented in the recent duodenal biopsy. And we have features of ongoing malabsorption in the form of positive D-xylose test. That is what essentially the investigations tell us.
How about the low platelet count? The platelet count on August 2021 was around 50,000 only, no? How do you explain that? Are we missing something?
Yes, I could not explain the platelet count with the investigations that we had.
Rajesh Kochar has already said that there is some elevated hemoglobin. Are we missing some hematological issues as well? Okay.
Do we have the renal functions?
Yes, renal function. We have the renal function test, sir.
Urine albumin.
We do not have the urine albumin at this
serum
point.
Albumin, but perfect. Serum albumin is perfect. It's only hypoglobulinemia.
Globulin. So globulins could be lost in urine. Either there's primary hypogammaglobulinemia or.
Yeah, he has already low IgG, IgM, and IgS.
Yes,
so
yes.
the common variable immunodeficiency is established with this test, and the duodenal findings of nodular lymphoid hyperplasia, giardiasis, that all everything goes together. What does not go together is the significant malabsorption. Jejunal biopsy is or duodenal biopsy is totally unremarkable or a minimal finding, and again significant D-xylose test. So there are missing points. That is what I would say.
Samagra, can you go just to have some learning experience? Can you go to slide of protein? Slide of protein.
Yes.
So look at to all of you. This point is very important in any patient with chronic diarrhea. And once we don't make a diagnosis clinically and we remain indifferent to diagnosis, looking at the serum protein value itself is a very important clinical parameter. That whenever you find that the low albumin, it's low globulin and normal albumin, always think of hypogamma in this setting of chronic diarrhea and confirm by doing IgG, IgA, IgM to confirm that is it only isolated IgA deficiency or it is a multiple immunoglobulin deficiency, confirmed diagnosis of CVID. One, if you have both low, both sodium is, if albumin is low and globulin is low, it means if pan hypoproteinemia, then you will consider lymphatic disorder, loss of whole protein, some amount of protein-rich enteropathy, which can occur in relationship with the lymphangiectasia, disease of into loss of protein, like Crohn's disease. So protein, looking at protein report, which we always ignore while looking at LFT, we are tuned and mind have been tuned to look at only albumin. Protein means albumin. We never look at globulin, but looking at globulin in patient chronic diarrhea itself, it gives you a diagnosis of this thing. Second point, if you look at any patient chronic diarrhea, you have low cholesterol. Although very rare disease, low cholesterol, low LDL, low TG, or think of A beta. But it is bringing difference in diagnosis as A beta lipoproteinemia, because cholesterol can occur because of diffuse absorptive defect. But if you have a cholesterol is very low, then you should also consider A beta lipidemia. And third point I want to make that although this patient diffuse mucosal disease, differential of celiac disease, tropical sprue, or for example, toxic disorders, you wouldn't like to do a luminal imaging like CT angiography. CT angiography will be a second level investigation. First level, there's no need to do a luminal imaging unless you're considering a luminal etiology like Crohn's disease. Then do a luminal imaging. So CT angiography may not be a great test to do as a first line if you're thinking of celiac or tropical or such disorders. All right. The Ramaksa make a point.
We are so far hinting at primary immunoglobulin deficiency. Still, do we need to rule out secondary like in lymphoma or renal disease? Do we need to go any further with that?
No, I think with the normal albumin, we don't need to do that.
Okay.
I still feel that with minimal mucosal biopsy findings, D-xylose test is abnormal. I think there's a question about D-xylose. Is D-xylose test a test of carbohydrate malabsorption or a test of mucosal integrity? It is a mucosal integrity. We are not testing carbohydrate.
It's actually, so again, may I just make a point there? It's not a test of carbohydrate absorption or of mucosal integrity.
Okay.
It's a question of mucosal surface. Surface area. You know very well, David Rolston demonstrated that this thing, it's surface area. Mucosal integrity, you'll have to do dual sugar absorption tests.
Yes, that mannitol
lactulose mannitol ratio.
Lactulose mannitol test. Okay.
There's a question from one of the participants that he received antibiotic multiple times. Would he consider a possibility of partially treated tropical sprue?
So here, this is something that we were talking about initially. That's why I asked this 3-month cotrimoxazole and tinidazole, which he received. And it led to prolonged resolution, say, for 2 years of symptoms. So it could be, I mean, looking now, it looks like it is common variable immunodeficiency with recurrent small bowel infections, which cause the diarrhea. But it looks like that a 3-month prolonged course did lead to a lot of prolonged remission of symptoms.
Another important point, just to enumerate out here, that to say tropical sprue, we say the chronic diarrhea is there in 100% patients, wherein celiac disease and other disorder is not at 100%. The reason being that thinking of tropical sprue starts from chronic diarrhea. We don't think of tropical sprue in those patients who come to with anemia or such disorders. Therefore, in almost all patients have that, whereas celiac disease, you think beyond tropical, beyond chronic diarrhea. You think in terms of anemia in those patients who have short stature or other clinical manifestations. Therefore, celiac disease have a less patient of diarrhea. Tropical sprue almost everyone has. The reason being that we start thinking about tropical once the patient has chronic diarrhea. A couple of more questions come that would it be still celiac disease? Although we have a more pointed towards CVID, but can you rule out celiac disease because his IgA TTG is negative? He's also IgA deficient. So does he also have a combined? We agree with you, Samagra and Mukesh, that this could be CVID. But does he has underlying celiac also, or have we ruled out completely?
Sir, I would like to make a comment. Am I audible, sir?
Yes.
Yes, sir. Very apt that there's an IgA deficiency, so we may not have a positive IgG test. But in this case, when he was put for 3 months on antibiotic and also on gluten-free diet, after 2020, he started taking roti, wheat and other product that could have gluten there, but he did not have recurrence of symptoms. So I would like to know as well whether at some point of time in history of celiac disease, consumption of wheat or gluten containing diet may not lead actually to relapse of symptoms for quite a long period of time. If no, then I think this excludes the possibility of celiac.
All right, there's another question from chat box that if it is CVID, then why does not he have features in the skin or respiratory tract? This is a question by or comment by Dr. Vivek Joshi.
All patients with a common variable immunodeficiency may not have all the typical symptoms because they agree that they have cyanopulmonary infection and GI infections. But here, of course, there is invariably proof of IgA, IgM, and IgG deficiency with the nodular lymphoid hyperplasia, giardiasis. So GA part is 100% certain, I think, in this case. I don't know about the other system. Usually, there may be cyanopulmonary infections also. That's the picture.
The other question is, again, the question has come that how would you now confirm CVID? Okay, we have a clinical suspicion has come that, or we also have a blood parameter suggesting low immunoglobulin levels, all three of them. But next step to confirm CVID, or you are happy to label him as a CVID? Okay, so but the answer to the question is that you will now, so these are the supportive evidences, but to confirm, we need to look at the beta cell switch memory, and for that we require a specific immune studies, which will not be available at every place. Therefore, if any patient chronic diarrhea, if we have a low IgG, IgA, IgM, you are almost certain this is a CVID, but you can confirm by doing a B cell switch memory tests. Other question is what about doing actually, if you think is celiac, would you do DQ2? Is a question by Chandrakant. DQ2 was negative in this patient?
Actually, DQ2 was in fact positive. And that was the reason for recommending gluten-free diet in this patient earlier on.
That makes it complicated.
It may not be that complicated because DQ2 may be positive in 30% of healthy individuals. So therefore, a presence does not make much sense. But again, if you have to think of celiac, then probably this is important test to look at. But DQ2 will be positive in 30% of
normal people. If it was negative, we could have ruled it out completely. So that ruling out is not possible now.
Yes, we should do IgG TTG as well.
True.
So I have
IgG is also low, sir. IgG is also low.
IgG is also low, yes.
So I have one question that when we have around 4 or 5 duodenal biopsies in this patient and none of them have showed any degree of intraepithelial lymphocytosis, even if let's say we find any evidence of celiac disease in the form of EMA positivity, will we strongly consider celiac as a cause of diarrhea in this patient?
So if we have an EMA positive, then certainly you have to, EMA is again IgA. So IgA deficiency, EMA may be falsely negative. But EMA is positive, then you will think of is playing a role. Also remember, this is some point of time, probably time we don't allow to discuss this today. But again, there's remember that intestine, skin, and blood are replicating cells, right? So they replicate every third day. The mucosa can get damaged and replace very fast. Despite being busy, they may not be evident on the biopsies. A couple of more questions take that would you this test will tell you vaccine response testing in CVID. Vaccine response testing for confirming CVID. Suppose somebody B virus and B virus antibody, vaccine of B virus. We don't have NTHBS. But this could be a pointer that this person is unable to make it. NTHBS IgG, defining deficiency. I think with this, if Dr. Kochar, Dr. Varghese, and Dr. Ramaksa allows, we need to close because we are at 1:15, 1:20 on a holiday and it's lunchtime. So if you agree, can we start the closing? Okay, so it has been a wonderful experience to discuss a case with chronic diarrhea and malabsorption. Samagra and Mukesh, you did a wonderful job to discuss and bring forth some of the important points which we wanted to highlight while dealing with patients with chronic diarrhea and malabsorption. Although 1.5 hours time is not the great time, but we made some very important learning experience out here today. And some of the important points to look at that while treating a patient with chronic diarrhea, we always look at this. You try to learn the approach to patient with systematic systematic order, and look at 6 or 7 points to confirm that where your disease lies. Is it small intestine, large intestine, if small intestine diffuse, or it is a local disease. And we had one of the uncommon patient, CVID, and the pointer was low globulin. So whenever you see patient with chronic diarrhea, always look at globulin level, which we are not reported on the biopsy, reported in the LFT. We get only albumin report. So total protein minus albumin is globulin. So always derive globulin report effectively. We just look at albumin and close by. So this couple of learning experiences, maybe close this session, maybe invite Dr. Kocher to say some words.
Yeah, I think it was a wonderful clinical exercise, thought-provoking, and with a lesson to all that how do you approach a patient of chronic diarrhea, and how to look at the smaller, finer print of globulins and go further than that. So thank you everybody for a good interactive session. Thank you.
Thank you, everyone. And thank you, Dr. Kocher. Thank you, Dr. Ramakrishna. Thank you, Dr. Verghese, for a wonderful interaction and making some of the important clinical points, which we should remember while dealing with patients with chronic diarrhea. With this, we close the session for today. And we will meet again. I will see all of you next week on Sunday at 11:30. Again, with a new case. And here you will be with more like intestinal obstructive disease, where there's an intestinal stricture, and how to approach a patient with that. This time we'll have patient from PGI Chandigarh, and we'll have 2 participants from PGI Chandigarh with a new set of faculty will join the session next Sunday. We'll look forward to see all of you for next Sunday at the same time using the same link. And as we go along, we'll have patients and residents from every part of country. So this was from today from New Delhi. Next time we'll have Chandigarh. Then we have a Kolkata, Hyderabad, Mumbai, Calicut, or Trivandrum, from every place with 12 different cases from 12 different places, with 12 different sets of residents. And we'll notify you who is going to participate at what point of time. With this, we close the session, and we thank you all, and we'll look forward to see you next Sunday at 11:30. Thank you so very much again, and have a great day ahead. Thank you, Dinesh, for organizing this. Thank you, Yogita, for organizing this session. Okay, bye-bye. Log off now. Bye.
Congrats to Mukesh and Samagra.
Absolutely fantastic job today. Fantastic job. Bye-bye.
It was a difficult case, agree.
But they did a wonderful job. All right, bye-bye. See you next week.